Hello, cardiothoracic surgery colleagues from across the globe. Welcome to this edition of the Cardiac Recovery Room. I'm your host today, Amanda Ray. I'm a nurse practitioner, lead of advanced practice, and clinical program manager for the Division of Cardiac Surgery at University of Maryland, St. Joseph Medical Center in Towson, Maryland. We're thrilled you're here today as we discuss important enhanced recovery after surgery topics with the help and insight of recognized cardiothoracic surgeons and clinical care providers. In this episode, we will be exploring surgical site infection prevention. Our guest here today is here to share her expertise and insights on surgical site infection prevention. I'd like to introduce you to Cheryl Kristofi. She is a coordinator nurse at Bay State Medical Center in Springfield, Massachusetts, an executive board member of the ERAS Cardiac Society, and recently published as a first author a turnkey order set on surgical site infection prevention. Welcome to the podcast, Cheryl.
Thank you for having me. It's an honor to be here today to be sharing evidence-based practices that can help patients and teams prevent surgical site infections for cardiac surgery patients.
Let me start with what drew you to be interested in surgical site infections and looking up the data and gathering this together as an order set for providers to be able to use at the bedside.
Well, Amanda, I think the reason that a turnkey order set to prevent surgical site infections was a project that the ERAS Cardiac Society thought was worthy of embarking on was because when these infections occur, they're often very devastating for patients. They're rare, but when they occur, they can be life-altering for patients. And about half of them are preventable. And how do you prevent them? Well, there's evidence-based protocols that you should have in place to help patients before, during, and after surgery. And that was the whole thing about putting this turnkey order set together, was to help teams to understand where they could impact preventing an infection. And putting all this, a nice bundled document that could guide care, we thought would be helpful.
So let's start with the beginning, risk factors. When we start looking at a patient preoperatively, what are the things that put people more at risk for surgical site infections in cardiac surgery?
The risk factors that we identified for surgical site infection for cardiac surgery patients include smoking, COPD, congestive heart failure, patients that are obese, if a patient has a bilateral IMA used during surgery, if they have large breasts, if person has had a history of radiation to the chest or has renal failure. We also identified malnutrition and diabetes as risk factors, as well as females and people that are immunosuppressed.
So some of these risk factors seem modifiable, others are not. So what are some mitigation efforts that we can do for our patients and have our patients do to kind of help reduce their risk of infection?
Great question, Amanda. So smoking cessation, glycemic control are probably two of the top things that patients can do.
So for smoking cessation, for example, how long is optimal?
If you have a month, that would be great, but any amount of time is better than none when it comes to smoking.
And postoperatively too, I
Absolutely.
assume. And what about glycemic control? So let's talk about some nitty gritty. We know in the ideal world, we would like to get somebody's glucose, their A1C less than 8 and then very controlled coming in, but we don't always have that kind of time in our patients. So let's say you have a patient that comes in and glucose is 500. Are we putting this person on an insulin drip to take them into the operating room controlled?
So if the patient's in the hospital and they're on your floor and they have very poor glucose control, it's a recommendation that you would use whatever you need to do. If it's not responding to your treatment that's on the floor, then yes, you need to consider putting them on an insulin drip and getting that blood sugar down near 180 before they go into the operating room. And when the patient's home, if you have an A1C that's over 8%, it's not feasible for most cases to wait until an A1C is less than, is back down to near 7. But what is an ideal situation is to get the blood sugar running less than 180.
What other modifiable things can we do for our patients?
Certainly, if you have a patient that's malnourished, you want to work on nutrition optimization. And even patients that aren't malnourished can benefit from improving nutrition, especially around protein intake before surgery. And another thing to think about, Amanda, is screening for infections on other parts of the body. So somebody could have something going on a lower extremity that isn't quite obvious, and you have to ask questions. If there's anything going on, and if you have time and can wait for that to be treated, that would be better for the patient.
And doing a thorough assessment of the entire patient, assuming that there's not a small toe wound or something of that nature, can be missed pretty easily if you're not being thorough.
Exactly, exactly.
Is there any other things that you can think of that we can do to help our patients reduce their risk of surgical site infection?
Yes, Amanda. We can screen patients for nasal colonization of Staphylococcus. If patients are colonized with MRSA, they're at a 9-fold increased risk for a surgical site infection. They're at a 3 to 6-fold increased risk of an infection if it's not a resistant strain of staph. In both cases, they would benefit from having a dose of mupirocin for 5 days, twice a day. And you may even want to add the CHG bathing for 5 days before surgery for those patients.
Let's talk about antibiotics and let's get to the nitty gritty of this. So, what are the best practices for what your antibiotic selection, the timing for the cases, especially if our cases are long and they involve like prosthetic materials or grafts? Talk to me a little bit about antibiotics.
When you look at antibiotics, when we wrote our turnkey order set, we really divided them up into 4 buckets. And yes, antibiotic prophylaxis is a cornerstone of SSI prevention. And 2 key things when you're talking about antibiotics is they need to be weight-based and they need meticulous redosing intraop. So let's go over the 4 buckets. The first one, which is going to be your patients that were screened negative for MRSA before surgery. And this is going to be the majority of your patients. And you're going to use cefazolin, weight-based, and redose it every 3 to 4 hours while the patient is in the operating room. Next is your patient that you have identified they're colonized with MRSA. You've treated them, but you're still going to add a dose of vancomycin, weight-based, to their antibiotic prophylaxis. So they'll receive the cefazolin as well as a dose of vancomycin that should be given 1 hour before incision. Then you have another bucket of patients. These are your patients that you don't know. There was no screening to see if they are colonized with MRSA, and they've been in the hospital for more than 3 days. They've been admitted from an outside facility, or they've been recently had given an antibiotic treatment, or you're planning to do a prosthetic valve or vascular graft insertion, and you may want to consider adding a dose of vancomycin to their prophylactic regime. The last bucket, which is relatively small, is your patients that have a documented anaphylaxis to cefazolin, and for those patients you would use a vancomycin and gentamicin.
So, if we're talking about our pre-op areas, what are sort of the specific recommendations for that team when they're getting somebody ready to go into the operating room?
Some of the key things that you want to think about is making sure that a patient does have a pre-op CHG bath before they go into the operating room. Any hair removal needs to be done with clipping method, no shaving. And you may want to consider using nasal decolonization, povidone for nasal decolonization if you didn't screen for staph and treat pre-op.
Once we get the patient into the operating room, prevention sort of becomes that responsibility of that surgical team. What are the key intraoperative measures to keep the field sterile, to reduce infection risk?
Think about your basics. So you want to follow all protocols for surgical hand hygiene, proper gowning and gloving. This is for every team member. You want to minimize OR traffic. Studies have been done that have shown increased traffic, increased airborne contamination potential. You want to make sure your instruments are sterilized and handled properly. Patients also need to have skin prep done with CHG alcohol-containing products, following manufacturers' recommendations for drying times on those. Glycemic control is very important. You want your blood sugar to be less than 180. It's often going to require an insulin infusion for your diabetic patients. Active warming when coming off of bypass. You want to achieve normothermia as soon as possible. We we recommend Vanco paste to sternal edges. And you may want to consider rigid sternal fixation for patients that are at high risk for a surgical site infection.
So we often hear about culture playing a key role in different types of care and different tasks that we provide. And it does play a big role in safety. And what does that look like when it comes to SSI prevention?
Great question. Really, what we want in the OR is for everybody to feel empowered to speak up. If somebody sees a break in sterility, whether that be a surgical tech, a surgeon, an anesthesiologist, anybody, they need to feel safe to speak up. The most successful programs focus on creating this type of environment where everyone owns infection prevention.
What do you think the SSI priorities are once a patient arrives in the intensive care unit postoperatively?
So once a patient arrives, you want to continue glucose control. Blood sugars need to be less than 180. And this may be not just your diabetics. You may have some stress-induced hyperglycemia. So you have to be on the lookout for that, and you have to really be managing that. You want to maintain normal thermia. And you really want to start working on teaching patients how to splint when they're coughing or sneezing to prevent dehiscence. You're going to be looking for proper wound healing and maintaining dressings, and also continue your antibiotic prophylaxis for 24 hours. And it's really all about detection, looking for things like fevers, signs of infection, redness, drainage, those kind of things.
And we should be teaching our patients that too as well.
Absolutely.
What about dressings for these sites?
The recommendation is an occlusive dressing for 48 hours. And for some of our high-risk patients, you may want to consider using negative pressure dressings, which have been shown when used prophylactically to decrease surgical site infections.
Kind of circling back to the patient education question I mentioned, how much do you think that factors in or should be factored in to pre-op prevention and education?
It's huge. Patients who understand why SSI prevention is important and they understand their role to help themselves prevent a surgical site infection can make a big difference in the outcome after surgery. This is going to help them stay on track for healing. And patient education is not just before surgery. They need to know what to be on the lookout for when they go home. So it should be ongoing with the team that's providing wound care. You also should be teaching your patients. Patients need to know about showering and bathing, not just before surgery, but when they go home, how to maintain cleanliness. And they need to know what to do when things aren't healing well. Who do they call so they can get help immediately? They also need to have follow-up care arranged so that their wounds are all being assessed and any escalation in care can be made in a timely manner.
It sounds like continuity is the key. And so you need to make sure that the prevention doesn't necessarily stop when the patient leaves, that we're making sure that they have the tools to go home to do what they need to be doing at home.
Yes, absolutely. It's a continuum of care, and it starts before the surgery, well before. It's during that pre-op time when you're working on optimization, intraop, aseptic techniques. Then post-op, it's vigilance on everybody's part, and making sure that the patients know what to do when they go home because they're in the driver's seat. If the glycemic control was poor before surgery, and they're not aware of what they can do as far as that goes, that can also impact it. Continuing those things that they started pre-op, smoking cessation, the healthy eating, all those things have to continue while the wound healing is going on.
Well, Cheryl, I think these are a lot of key pieces that we can take to the bedside and apply as bedside clinicians. And I think taking academic guidelines and consensus papers and putting them in digestible form for the frontline providers is key. This has been a great discussion. I want to know if there is one thing that you feel is more important or kind of stands out when it comes to SSI prevention.
I think we really talked a lot about it, how it's very much a team effort and the team includes the patient, but there's a lot of people that touch the patient throughout their recovery and their pre-op journey. And really, it's any break in that team that can make or break whether a patient has a good outcome here. We didn't talk much about the turnkey order set, which is something that the ERAS Cardiac Society worked on as a group. And this is something that really can help teams make sure that they're embedding the most up-to-date evidence-based practices into the patient's care so that these things seamlessly happen for patients. So giving a plug for the SSI Turnkey Order Set, which is an open access document that teams can use. Checklists are another great tool. We have a checklist in the Turnkey Order Set that teams can consider using. And the other thing that if you do have one of these devastating surgical site infections, take a deep dive in, take a look, and see where there are opportunities missed so that you can help prevent that from happening to another patient in the future.
Well, thank you so much for taking the time, Cheryl, today to spend time with us, and thank you for giving us your expertise. I want to thank the audience for listening. And join us next month as we continue perfecting patient care with an ERAS Cardiac Society and CTSNet podcast.
Thank you for having me today.
Bye-bye, everyone.